Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, Hee Hee. Now let's get to the good stuff. Dr. Wood, welcome to the show.
Hello, good morning. How are you?
Hello. I am excited to talk about your new invention. I think it's going to be such a game changer in reducing the number of C-sections that we do here in the U.S. specifically, but like globally. I just think this is going to be such a good thing to have access to when it comes to birth. But before we talk about your new catheter, I want to talk about a couple of things that maybe lead to unnecessary C-section. One of those that we often hear are epidurals. So as an OBGYN, you've been practicing for a long time. Can you tell us the trends that you've been seeing or that you have seen with epidural use? What are we seeing today versus what you used to see when maybe you first got started?
So when I first was in practice, and I've been in practice about 25 years now. So when I first came into practice, the typical thinking with the epidural was we were told to make sure that the woman is in active labor before getting an epidural. And the reason being is because it was felt that it may increase the risk of C-section or slow the labor process down. So usually we would bridge that period of time with either narcotics or coaching and things like that. Now, today, probably for the last several years, that has changed completely. And now the way it's practiced now is that the epidural is on demand. So whenever the patient or whenever the woman wants an epidural or requests an epidural, she's given an epidural. And that could be an active labor, that could be the early part of labor, or that could even actually be at the very beginning or even before active labor.
Okay, you just mentioned coaching. Tell us a little bit more about that. What kind of things were you coaching them on?
Just basically coaching the patient on expectations, kind of what to expect during the labor process, what to expect of the pain, things that she can do on her own or with her doula or her labor coach, like breathing techniques and things like that, kind of help get them further in the labor process, because everybody's different. And so some women do well with a natural labor process, coaching, and are able to go through labor without epidurals or without assistance other than some coaching. And then that'd be one extreme. Then the other extreme would be someone who opts for an epidural on the very onset. And then you have all types of degrees in between.
Do you recommend epidurals be gotten at a certain point, or do you have a preference of maybe what your patients do?
It's the patient's the one who has the pain. So it's not my pain, it's her pain, correct? And I think that she's entitled to have control over her labor and situation. And so I feel that when she's ready for it, and I think that you want to make sure the conversation is open and that you've got an open communication so that she knows that she can ask for what she's wanting, or she can at least ask for information and make a decision on what she wants.
Yeah. I think a large part of the conversation that's often left out too, and I think a large part of that is because prenatal visits are so short. They're very crammed in there, and a lot of times, and I think the conversation is not had in so many instances about what other options you have and the benefit of waiting a little bit later. So I think a lot of people might change their decisions if they had an open conversation of there might be benefit to waiting later in labor.
Yeah, and exactly. Some of the benefits and the cost. The cost might be we might have to endure a little bit more for a little bit longer, but here's the avenues and here's all the things that we have to be able to do that. So that, A, you don't want her just feeling like she's just left out there alone. She wants to feel or be supported during the whole process, and not only support being there for her needs, but also supporting and understanding what her goals are.
Yeah, that's amazing. Gosh, I wish all providers were able to have these conversations about, okay, here's what you can do and utilize in early labor. Here's what we can do in active labor. Here are some pros and cons of each of these choices. I know that's impossible in some cases, but it would be helpful. Do you recommend your patients have doulas? You mentioned doulas earlier.
Yeah, I think again, it's everybody's different. I think they provide an important aspect to the process. Some women don't feel like they need other support. Some women come in, oh, I've done this a couple times before, but some people just like having an advocate. And I think the doulas are great advocates for patients because sometimes their job's to help speak up for the patient when maybe they can't speak up for themselves, or
Yeah.
or maybe intimidated or what have you, or just scared to say something.
Yeah, totally. Okay, while we're on the topic of things that cause maybe unnecessary C-sections or may influence this, can we talk about failure to progress? I teach a class that is it's focused on helping people identify reasons that a C-section may not necessarily be their only option and what kind of questions they can ask to determine if they have other options. And one of the things we talk about is failure to progress. One of the things I've learned about failure to progress is that many people who are diagnosed with it don't actually meet all of the criteria. And I found that so interesting. So, as an OBGYN, what do you know about failure to progress that consumers, patients need to know in order to make informed decisions about that?
Right. Currently, about a third of women end up with a C-section. And when you look at that third of them, about 60% of them are falling in the category of failure to progress. And to be honest with you, I don't think anybody fully understands the whole picture of that because there's so many factors involved. And so once you exclude like fetal distress or malpresentation, some of the things that just we don't really have control over, and we end up with these. The phase progresses that category includes the women that come into labor, or they're put into labor, or they're induced in labor, and they just get to a point where there's no further descent or there's no further dilatation. When we go and sometimes we'll put arbitrary times on them and various things to meet certain criteria. You really got to look at what's failure to progress. So to progress through labor, it's going to take a combination of three things. It's going to be the passenger, which is the baby, and then the passageway, which is the pelvis, which comes through the inlet and the outlet. The inlet and then the outlet here, and the power, how well the uterus is contracting. A lot of times we tend to, as providers in labor, we tend to focus on the uterus. We just need to get it more contracted, harder, more frequent, more intense. And we have all kinds of ways to monitor that. Intrauterine pressure catheter, which goes up through the cervix and lays inside the uterus to measure how frequent the uterine contractions are and how strong they are. So we can see if they meet certain criteria to determine adequate. But a lot of times we get so focused on the Pitocin, the Cytotec, all these other medicines that we have mainly geared to starting labor and pushing that uterus to contract. We forget about the other things that are involved. Baby, or the passenger in the passageway. And I feel like with the passenger, granted, there's not a whole her shape and presentation by movement. If the baby's a little bit more flexed or a little bit rotated, a little bit different, having the patient get up and ambulating, doing various maneuvers that midwives, doulas, and nurses are familiar with, we can do those positionings, and in a way, we can modify how the baby's positioning. In some cases, not all cases, but some cases we can. And then that may facilitate further progression and complete delivery and labor and delivery. The other things is the pelvis. Now, there's not a whole lot we can do with the pelvis. Now, moving and repositioning can change the pelvis around, and in a combination of the baby as well, which can help. But there's some things that we may be inadvertently doing that may be causing some complications, if you would, or causing difficulty with the progression of labor. Some of the things, like you say, with the epidural, it does great for pain. However, it decreases mobilization of the baby. The mom can't get up and move around very much, right? So then we're limited to things that we can do in the bed. When patients get an epidural, they are unable to empty their bladder. They're not going to be able to sensation when their bladder is full or not. We have to deal with her bladder, because if you leave the bladder unattended and it gets full, now you've got this big bag of fluid here that can cause obstruction of the baby and decrease the ability for the baby to come down. And then the other thing that you have is what we call iatrogenic. That's when we do things. So when we place an epidural to manage a woman's bladder, they get a catheter, a Foley catheter, which gets placed through the urethra and into the bladder. Here's the bladder, here's the pubic bone, and here's the vagina, and then the cervix. Now, this particular model, which is a really nice model and was loaned to us today for use, and I'll provide the information for there where you can get a model this or any other anatomical part if you want. So if you notice here, this baby's in a pretty advanced station. The baby's pretty well engaged in the pelvis. It's a little further in, as if you would be in labor. But when you place the Foley, it's held in place with a little 10 cc balloon. And that balloon is 3 centimeters in diameter. The important measurements here, that from the pubic bone back here to the sacral prominence, is about 11.5 on average centimeters. But the baby has to negotiate that coming through. And then down there by the base of the coccyx right here, this is the other one for the outlet. Again, that's about 11.5 centimeters. Let's just say 12. When you place this Foley catheter in there, you now have 3 centimeters you've taken away from that diameter. So now, which is almost 25%. If this baby, which, like we said, we used to wait until they're active labor, and basically when the baby's down engaged, when that happens, it's fairly easy to get this balloon above the fetal head. Right? We typically get the epidurals much earlier than that, when the baby's higher up into the pelvis, and sometimes even sometimes before they have actually engaged the pelvis. When they do that, there's a much higher risk of this Foley becoming in front of the fetal head. I hope my arm's not in the way, and catches that inflated catheter, or tries to come through a much narrower space created from that 3 cc balloon between these points. And so what I found in my patient population over several years, about 1,500 patients, when I first noticed this a long time ago, I started checking for it, and it was almost 20% of the time I would find that balloon in front of the baby's head. And I was concerned that if that wasn't caught, or my thought is, I've caught it, but I've found that when I've caught it, that means there's been 2 or 3 other people, nurses or whatever, who've examined the patient, informed me that they're not making progress. And then when I go in and check the patient, and I've noticed that Foley, and where others haven't, it made me really concerned that this is happening enough in my practice this is worldwide and nationwide. This has got to be an issue. And so I just stopped at that time. I just stopped inflating the Foley catheter. Whenever I had a patient have their epidural placed, I just no longer inflated the balloon for the catheter. And so I would just leave this in place without it. Now, the problem with that is it frequently came out. It caused more work for the nurses. And a lot of times the nurses would just sneak the saline back in there so they wouldn't come out. And when you frequently try to recath somebody, you increase your risk of infection and stuff like that. So I just started trying to decide, all right, what can I do to make sure that this thing stays in but doesn't cause a problem with catching the baby's head? And so my idea was with the Foley is similar to this, pretty much a similar type Foley, except now this is just a demonstration because we're trying to create this. We don't have an actual device yet, but it's a process. But on the one that we're creating, it simply has a much smaller profile. It's almost like a pancake shaped circular piece there that allows, when it's in place, when the Foley's put in, it's inflated, and then this piece will sit in there in the bladder. And what happens is it gives, and it has a flap effect. So when the baby comes by it, if this was sitting in the bladder here, this is what would hold it from coming out. It's a very low profile, probably has about 3 cc's of fluid in there, and it's flexible. It's able to move up and like this, like a flap, if you would, like
as
a gate.
the baby's head comes down.
So as the baby comes down, if this happens to be now, the way the Foley, the way the catheters are managed by the nursing is it goes up over the leg. And since it goes up over the leg, it tends to make this flat up against this wall of the bladder, so it usually gets it out of the way. Whereas in the 10 cc balloon on the old catheter, it actually pulls that balloon in front of the baby's head, makes it even more likely to catch. But with this design here, if you see it, if it was in front of the baby's head, what happens is the baby's head comes down, it just gives, and it just flaps right by. So it goes right by and it doesn't catch. The other thing, and you might notice, whenever there's a shoulder dystocia, so whenever we get worried about a shoulder dystocia, that's after the head comes in the shoulder. The reason that occurs is the shoulder gets hung up along this part here, okay? That just further shows us the problems that having a 10 cc balloon right here. Now, most of the time it's not going to be a shoulder, because what happens, we don't see it as a problem with the shoulders, because when people start pushing, the Foley's usually removed, right? So we don't ever have a problem with that there. But if you think of the head similar to the shoulder as it's coming past this area of the pubic bone, when you've got this balloon sitting there, it's just sitting right there asking to be caught by the fetal head. And again, what I've found is about 20% of the time. And when you look at those numbers, that's probably running a risk of about 40,000 patients, I feel like, in the United States, are probably ending up with a C-section because of failure to progress, because it's been limited by that Foley pole. And when you look worldwide, you're looking about probably 2 million people worldwide.
Wow.
Which is quite a bit. And so we're always trying to understand failure to progress. We're all trying to reduce that number. The World Health Organization says that the C-section rate, primary C-section rate, ought to be between 10 and 15%. What we're worldwide, we're about 30% is about what we're running now, 1 in 3. So we have a long way to go. I've pretty much have eliminated, I've eliminated an inflated catheter in my practice for years.
Wow.
My C-section rates runs about 13%, close to 15%. And average it runs between 13 and 15%. And so I feel like that this has a big factor in what's going on. And if you want to think of it in the simplest way, it's like people who have medications, like Some people may take Benadryl or Tylenol or something, and we have a regular dose. Benadryl's 25 milligrams and Tylenol's 500 milligram tablets. Some people know themselves. They say, that's too much for me. And they break them in half. They take a smaller dose, right? You can think of my catheter is like getting a smaller dose, if you would. You're looking at the maximum dose versus minimal dose. And so I feel like in dealing with this failure to progress I feel like we need to back off a little bit and let nature do itself, because nature wants to do 10 to 15%, right? That's what it wants to do, a C-section rate of 10 to 15%. And so I'm sure inductions and our criteria for what we call failure to progress, I feel like all those probably have some influences on our C-section rate. But any chance that we have to, or any way that we have to try to prevent any issues, and sometimes it's difficult to know what it is that's causing the failure to progress, but I at least want to eliminate this factor, because I feel this is a significant factor that's really not recognized as like it should be. Mm-hmm. And by doing that, we are in the process of creating this so that it'll be available to every woman in all the hospitals worldwide. And again, our goal is to try in making that available to everybody. We're trying to keep the costs down to the same or better than the traditional Foley that's being used. And part of the reason we have so much having so much trouble getting things moving down the road is that a lot of people aren't interested in big pharma and big medicine, aren't really interested in these devices and other things like it when there's not a lot of money to be made on it.
Yeah.
And that's where we are today, is we're trying to secure and get our funding so we can help make this a reality for everybody.
Yeah. Before we go into all that, the water or the saline that's in the balloon of the one that we currently use and the one that will be in yours, but just in a much less, amount. Mm-hmm. It doesn't squish easily. You recently visited me. Yeah, you recently visited me and shared that it has to be displaced somewhere. Talk to us about long-term effects that might come from having that catheter displaced in your pelvic region for hours at a time.
So this is the inlet of the urethra, okay? This is the outside part of the urethra. This part is the urethra is in the bladder, okay? And so this Foley designs is basically designed to sit right in here, because this balloon is basically meant to keep it inside, right? It's keep it from coming out of the bladder. Same thing with our little pancake, keeps it from coming out. So it sits right here. And as the baby's head comes down here, and if it catches this, what happens is it starts to put pressure and starts to pull this direction. All up here is connective tissue that helps support the urethra up against this angle. And that angle is important in relation to the bladder to help prevent incontinence. And so when you've got injury or damage or pulling of that tissue down, which it occurs in just normal labor, even natural deliveries, it to some degree, depending on how much difficulty the mom has of delivering the baby. But particularly when you have a Foley, because you have no sensation, your pain's all blocked, you would have no sensation of what was going on or that anything was happening. That just starts to pull and puts pressure. And as a lot of people who've probably been in labor themselves, and doulas and midwives, when people have been laboring for a while and not making progress, tissue swells. And even when they do make progress, when they tend to have longer labors, sometimes the labia on the outside will swell, some of the vaginal areas. We've all seen patients that have had significant amount of swelling, and thank goodness we have ice and ice packs afterwards to help. But that swelling also goes into places that we can't see very well. The cervix, I think we've all seen patients or had patients where their cervixes have been so swollen from the head just continuously hitting on the cervix without it moving out of the way. And the other issue here is along the anterior vaginal wall is where a lot of nerve innervation for sexual function and what they call typically the G spot is located in this area. And this whole area in here is really impacted when you've got a dystocia that is caused by the head catching this little balloon. And it's difficult to quantify. I know that it happens. I've seen it happen. What's the extent and what's the long-term consequences and how much it actually is affecting the failure to progress number. It's difficult to put those numbers without a big randomized controlled trial and that, which again, that costs lots and lots of money. And unless someone or a large company or big pharma, big med feels like they can make a lot of money on the device, they're not going to go through the trouble of doing that. And so I think that's why it's just never has surfaced. That you just really have to be thinking about it in order to realize that it's there and it's obstructing. Because numerous people, I've occasionally gone in and done an exam, and after my cervical exam, I thought, you know what, I didn't check for that Foley, and I'd go back in there and you know, apologize for having to re-examine again, but just check to make sure that it's not an issue. So I've tried to train myself to every time when I do a cervical exam, when they've got a Foley catheter and epidural in place, to be sure to palpate for that. And
So why not just make that part of all the training of all practitioners, midwives, nurses, doctors, residents, nurse practitioners? Just if you serve someone who's in labor that has an epidural and a catheter, why not just make that part of the exam?
Yeah, and I think that would be great, except I will tell you, that probably won't solve the problem, because when I have found it and have pushed it out of the way and thought that it was the problem solved, I would come back and it would be back in the way again. And so, and I've seen them deflated to about half the volume, and it's still, we're still messing with this space that Mother Nature has to work with. And so my thought is maybe we can put something in there, maybe we find it, maybe we don't, or we rely on all kinds of people to have all kinds of training to may or may not find it, or just get rid of the problem, or just get rid of the issue and place a catheter that I don't have to worry about it. Mm-hmm. The patient doesn't have to worry about it. It's a non-issue. And at least we can take that off the table in this dilemma that we have of failure to progress. And it's like all kinds of, it's like other problems. Sometimes you've got several factors in there that are causing the problem. And the best way to do it is just start eliminating the ones that you know are factors. And that's all I'm doing. All I'm doing is let's eliminate this factor. And hopefully we get down some. Hopefully we'll bring it down. My hopes is that, and what I'm seeing, I'm thinking it might knock off 20% of that 60% that's failure to progress, which would be a significant number.
Yeah.
And even if it was half that, it would still be an achievement.
Yeah. Yeah. Any number is a good number. So before your catheter hits the hospitals, because this is obviously the dilemma we're facing, is being able to get it into hospitals. If women have a Foley catheter and they find themselves having the discussion of failure to progress, what are some options that they can do in that moment? My brain goes to deflate it all the way, and let's just take our chances with it coming out, and then immediately get your hips in different ways. Let's really get you up on hands and knees. Let's adjust the bed. Let's get a squat bar. Let's get a birth ball. Let's get a peanut ball. Let's do different maneuvers. Is that kind of on the right track of what you would suggest?
Absolutely. Absolutely. Because all those things that you mentioned, you're affecting the passageway and the passenger. We've gotten really good at the power part. We've gotten really good at that. We've got Pitocin that can do that. And we can turn it on. We can turn it off. We can adjust it. We can do all kinds of things with that. But I don't feel like we're doing as good a job as we could with the passenger and the passageway. And it's just because we got to think about that. Those are just as important as the power. I think we all get focused on, the uterus isn't contracting enough. And then when we do get the uterus contracting enough, and we're not making any movements, then it's just nothing else can be done. What have we done to help the passageway? What have we done to help passenger, right? What have we done for those? And I think going down that list of things that you said are vital into giving the woman every reasonable possibility of having a successful vaginal delivery. That's what she's trying to accomplish.
Yeah.
And my thing is, I just want to see this out of the way. I just want to see this gone. And so that factor, that issue is off. And right now, what I'm left with to manage my patients is I never inflate it. Once they put it in, I never inflate it, which puts you in a battle of evils because of good and bad. Because yes, I've gotten rid of that, but now if we try to move her around and do the other things, this will probably come out. The Foley will probably, the more we move around, since there's nothing to retain that, then that Foley catheter is liable to come out. And then she's probably going to need another one put back in, or straight cathetering. And of course, every time we put something in and out, it runs the risk of infection. And so it's not the greatest, but I feel like it's plays a significant enough factor that it's worth completely deflating and trying to manage keeping it in place.
Yeah. Do you think that it would be an option, or would it be, I want to say, would it be ridiculous, but then I don't think any option discussion with your doctor is ridiculous. Do you think there's space for people to ask their providers to only inflate that Foley catheter a little bit? So maybe they say, like, I would only like it to be inflated 3 cc's or halfway, please. I don't want you to inflate it all the way.
Yeah, it's reasonable. You can ask those things. And again, having that down to 5 cc's, let's just do that right quick. And we could drop that down half. It still has a presence. It's less. It's better than being full. I was going to say better than nothing, but it's not better than nothing. But once you take it all out, that's what. But it's better than having the full 10 cc's, because now you're probably more of a line. You probably about a 1.5 to 2 centimeters diameter instead of 3 centimeters diameter.
Could we see 3 cc's and see what that looks like? Yeah.
Yeah. No, yeah. Let's get down here.
When you see it, I want to know if you think that would keep that in.
What happens is the smaller you get, the more chance you have of pulling that through, because it has less. Yeah, that would probably hold it in some. Now you can still catch some, but the other thing is now the smaller you get here, because the way it's rounded and the way it'll do, you have a higher chance of that pulling down into the urethra. And that could cause some injury to urethra if it gets caught and gets pulled.
Like what?
All these catheters, even when it's fully inflated, even with mine, if a patient was moving around, and let's just say she just happened to put her knee or something on, or her Foley bag or something got caught on something, and she moved beyond the limits of the stretch of the thing, it'll pull it right out of the urethra, which, that'll probably hurt, probably cause a little blood in the urine and everything else, and cause some a little bit of damage to heal, but it can cause some damage. The smaller you get with that, the greater the possibility of that happening if it gets caught. Does that make sense?
Yeah, the greater the possibility that it comes out, but I have to believe that it's less risk of injuries because it's smaller. You would think that
correct. The bigger it is, that's correct. So it's not as much.
Definitely.
It'll do less damage, but it's easier for it to pull out.
Exactly. Yeah, for sure. Okay, you keep mentioning power, and you have said, like, that is Pitocin. I would love to know your opinions on Pitocin and have your maybe approach to Pitocin use, understanding that Pitocin obviously is way overused and is largely responsible for probably the rising C-section rate, just because of the inappropriate use, not because of Pitocin itself, but because we usually use it in a way and in times that we don't need it.
Right. Exactly. And it's using things and the art of medicine and getting better at things. It's a learning process, right? It's a learning curve. And when I first come out of training, let's get the pit going. And over time, during my practice, and this happens everywhere, what ends up happening is you follow these protocols, right? The hospital set protocols for Pitocin, and these get put in place so that you can just order the order set, and then that kind of gives the nurse in a way, free reign to go as long as she's within the protocol, a lot of times just take off and manage that. And so a lot of times what would happen is Pitocin would get going, it'd get up to 2, 4, 6, 8, 10. Then all of a sudden baby gets distressed. You get a phone call, had to turn the pit off, baby got stressed. And that tends to be a recurring theme, right? And then when you do that, you've turned it off, you wait a while, and then you got to start back up because you typically don't turn it right back on. And so when I've noticed a long time ago, these things happening, I'm like, that's just a waste of when that happens, there's a big period of non-productive time there. And
but you're
so,
still feeling those contractions. It's not like,
it's not like they're off, right?
Yeah.
As I've matured in the practice and over the years, I've realized I've taken the step. Why are we in such a hurry, right? Why are we in a hurry? Let's just do what this patient's body wants to do, right? And so, to me, if it's an induction or if it's well, let's say the water broke and they're not really contracting, but there's an indication for Pitocin, I've much more common for me now to start at a much slower pace and start listening to the patient, start listening to her body in terms of how frequent are your contractions? What's the pain scale? Do they hurt? Are they mild or moderate? What has been changing? How is the continuum changing, right? Patient's going to tell you if you ask them, if you talk to them, they'll let you know what's going on. And if you just listen, you'll understand what's going on. Now, of course, when they have an epidural, it's a little tougher. I've got to look at how's the baby tolerating, what's the uterus, how frequent are the contractions, and palpating to see how firm are they and how late they are. If you just do an assessment, you can get a pretty good idea of what's going on. And then I just monitor her labor progress. Is she making some progress? And so I set out what my goal has been now for quite a while, is not how fast I can get my Pitocin up to 10 or how quick I could get it up, but how low I can go and make progress. And so once I'm confident the patient is making some progress, then there's no reason for me to continue to add that. And I get phone calls all the time. Do you want me to go up on the Pitocin? Or even I'll examine someone. It shows me is there's a lack of clear understanding what the medicine's used for. Because a lot of times a patient will be on 2 or 3 and she's in early labor. I come in and evaluate her and I'm like, oh, wow, wonderful. You've gone from 2 to 4 centimeters and now from 50 to 80% effaced. Good job. And let's just keep doing what we're doing.
Yeah.
Right. And let's just cruise. And then as soon as I finish that conversation and start to have a smile on my face about it, I usually get asked by the nurse, do you want me to continue to go up on the Pitocin? And so when I hear those questions, now I know they're probably confirming or not, but to me, I'm like, do we understand what our Pitocin is for?
Why would we do that?
Why would we go? We're making progress. Why? We're just throwing more fuel we're just making a bigger flame that we don't need. Yep. And making more of a chance for the baby to get stressed out. And so I feel like that we've got to get a better understanding of mom's time, nature's time for each individual. They're different for and I think that's one thing we got to keep in mind. Everybody's different, right? Now, a lot of people will be fall in that average range, but there's people, a significant amount, that are going to be above average and some below average, right? And so we just got to be patient and see where they are and listen to them and see what they're trying to tell us.
Yeah. Okay. That was amazing. Thank you very much for that. I knew all of it, but it's always just very nice to have an OBGYN confirm that we're not crazy, because as women in healthcare, it can really feel like very gaslighty. It can feel like we're always being told that what we know to be true is not true. So it's just very nice to have that confirmation. As we wrap up, one of the things that's very nice about being in this community is that I keep it super up to date, the hottest and newest things we're talking about. But what that means too is sometimes there's a wait in being able to actually access it. So that's one of the things that you are dealing with. So as people are learning about your new device and it's not in their hospital, how do they start to push their hospitals to get this device there so that it is an option for people?
So currently, right now, so I personally have gotten this thing, the idea of going with this, and I've gotten the full patent on this, and I've gotten a good start on this product. And so for about the next 4 months, this is August 1st is when we actually, so I got the patent back in February, completely done. That's been like a 3 or 4 year process. I had no idea. And so since February, I've been looking for the best fit to help me complete this project and actually get it to the shelf in the hospital so patients can have it. And so I came across a group of Vitatech. It's like a device incubator is what they call that. That's their magic word. They use incubator. I guess they're trying to take the little egg and hatch it into the new device. And so I think that's where their thought process is. And so I feel like that they understand the product, they understand where we're going, and most importantly, they're passionate about the idea. And I feel like that they have going to help us do this at the most reasonable cost and the most reasonable time, which is much lower cost and a lot faster time than anybody else that I've seen out there. And so our goal is to try to have this available for patients by the end of 2025, which is just over a year, which is pretty incredible when you're talking about getting something from a little more than a sketch on the paper to a patient actually using it. And right now, I've got the ability to get us through phase 0 and phase 1. I've financially secured that, and that's about 4 months. It's going to take us to get through that. And at that point, we will actually have a high fidelity functional prototype. That'll be actually what we will have. And then we will have all the all the regulatory, we'll have everything lined out. And from that point, it's just building the machines, build the things, and get everything in line and getting it into the hospitals. The big obstacle with that is, of course, is financing and money. And 4 months from now is when the big obstacles in terms of financing is going to be our next issue. And what we're doing, we're trying to be able to, what our efforts are is to try to keep the cost of these down very low. We're not in it for money. We're in it to help solve a problem. And we want to be able to get this worldwide. And we're doing that. We're trying to get this to a cost point that it's functional enough that it'll be able to self-sustain itself, if that makes sense. And so that once we get the product out there, we want to be able to keep it out there, correct? And one of the ways we're doing that is not only with some individuals' personal funding, but also with the crowdfunding. And that's why when we met a few weeks ago and talked, and I'm glad that we were connected because we both have a passion for what we do, and we have a lot of common interest with this. And so I reached out to you to tell you about what was going on, and you felt like we have a community out there that can help. And so to make this available to either women who are planning on being pregnant or have daughters or family members, there's somebody is going to be able to use this at some point. And there's probably people out there that are probably, I wished I had that. I've had some experiences that I wish I didn't have, and hopefully this will prevent others from having that problem. And so we really need just a lot of people to be active by giving into our cause so that we can help get the big financial hurdle of this done.
Yeah.
Does that make sense?
Yeah, absolutely.
Because
I have a fever.
honestly, if people don't get involved and hit the button and donate, even if it's a little, a lot, obviously a lot is great, but even a little and that's why we're approaching trying to get a little bit from a lot of people instead of a lot from a few people. And everybody might say, wow, it's great. But it's going to take more than that. We need to make sure everybody's informed that knows about it so that they know that they have options when it's available, that there'll be an option for you. but it takes more than that. It's going to take a little giving so that we can get.
Yeah. I have a few rapid fire questions for you as we wrap up here, okay? About
Okay.
the giving campaign that I know people are going to want to know. So if you donate, what will that money be used for?
So that money does not pay for my hotels. It does not pay for an office. It does not pay for office staff. It does not pay for me. It goes, that money will go from the donor link into an account that's for this, and that money, every bit of it, is going to go to the company that's down there looking at materials, making materials, testing the product, getting licensures, getting everything that is going to have to be done to get this in the hospital. That's the only thing that money's going for. It's not going, it's not subsidizing an office. It's not paying us salaries. It's not doing anything except going straight through to that development company to get developing. And then I meet with them, and I'm glad you asked that, because that's where the money's going, but it's not just going blindly there. So I'm your eyes on the ground. I'm your boots on the ground, if you would, because we have, and that's one of the things I like about them. We had a kickoff meeting August 1st that we were all on the same page, that we got this started every week. So it was last week when we started. So tomorrow we have a video conference, a progress conference, and we have a progress conference every week. So I know exactly what's going on and what's happening, and that the money that we get is being used like it's supposed to be used.
Nice.
So I'm there to make sure accountability is done on the company that's there. Also, I'm in a direct contact with all the developers. They pull me in the loop. So when they're sitting here working with materials and working with designs, they have access to me. So it's not like they're going to spend 2 or 3 weeks making a whole bunch of going down rabbit holes or going different directions and then come to me and say, oh, guess what? This is what we came up with. Is that close? No, we're in constant communication. This is almost going to be a unpaid full-time job for me, monitoring this and keeping this thing going, because I really want to get this out there as soon as possible, which is hopefully by the end of this next year. And we feel pretty comfortable if a lot of the goals that are met, it could be as early as 9 to 12 months, but we're looking more at 12 to 14 months is what we're planning on. And that way, if it's sooner, it's just icing on the cake.
Sure. So research, development, design, manufacturing, and distribution. Cool. How will
Correct.
this compare in
Let me
price
add
wise?
something. Let me
Oh
add
yeah,
something.
go for it.
Let me add something.
Mm-hmm.
So if you look if you go to the website, now we don't have a fancy website. I'm not spending a bunch of money on a big fancy website. So if you go to the website, it's a fairly simple website, but there's some more information. There's a more information button that'll flash at you. You can get there and you can read more about what's about this project and the issues. And you can also see the people that are working on the project there and their backgrounds. But what's important is on like this, the third and fourth page shows the different phases and what all the work that has to be done in all 5 phases. And right now, phase 0 and phase 1 are on one page because that's funded. Those phases are funded. And so you can see those and all the things that we're going to be doing over the next 4 months. And then the phase 2, 3, 4, and 5 all have the things that are going to have to be done on those. And that's going to be our next phase. And that's going to be running about $750,000 for those remaining phases. And so we're hoping that we'll start pecking away at that now. So by the time we get 4 months, we'll have the resources to continue. What I don't want to end up doing is in 4 months, we've got to stop and then start looking for funding to continue. And so there's ways people can do one-time donations. We'll keep them involved and keep them accessed. And if they want to give on a regular basis more than once, that would be great too. But we're looking at this as a big team effort. Team everybody, the team community. It takes a village, right? It takes a village. And that's what we're trying to do, is reach out to the village so that we can do this right without having a whole lot of various problems, issues, and influences from big institutions and stuff.
Yeah. To all the people who want to see clinical trials before it's used and really question its credibility because there is no like true data behind it, it's more observational. Although you do have significant observational data, what do you say to those people?
So that's a great question. So what we anticipate is this to be a class 1 with the FDA, which means the FDA, because there's a Foley out there, right? There's the one that out there's a 10 cc's. This one is much, much less invasive, if you would, or has a much less presence than the other one. And so we're confident we'll probably get a class 1, which means we just register with the FDA and they follow it along. But what's also pretty neat about this, the situation is, since there's nothing else like this, we feel it's going to be considered breakthrough technology. Now, when someone told me that, the developers told me that this will most likely classify with hospitals as a breakthrough technology, and I'm thinking, well, it's not rocket science, right? But it doesn't have to be. It's something that's unique, that's different, that solves a problem, and there's no other solutions for it. So it's considered breakthrough technology. And with that designation, a lot of these big hospital groups, these big networks of hospitals, these organizations that kind of manage several hospitals, tens and hundreds of thousands, millions of patients and stuff, a lot of times this allows these breakthrough technology, they allow those to be introduced, and then they monitor them as if a mini clinical study in their own environment and population, and they will monitor it and get feedback on it and compare it, and then that's a way for us to get feedback on it, and eventually we'll have that out there. But it will be available without that. It's just because of the class situation that it's in, and because it's similar to there's another device that's out there, which is a similar but not similar, right? It's the Foley. That's the most closest thing to it. And the catheter that's been out there now has been out for decades. It's been out probably almost maybe a century. It's been there for a long time. And since this is a less intrusive one of those, it really makes it easier for us to get it into the hospitals through the FDA. But it will be monitored and feedback.
Nice.
Does that answer your question?
Yeah, absolutely. Absolutely. Cool. This has been such an informative conversation. I'm really excited for your device. I'm excited for you to hopefully get this out and for people to be able to start using it. I'm excited to see the impact that it has on C-sections in our country. I just think this is really neat and cool. I think it's awesome. I'm excited for this. This is really neat. I think all good ideas start from something observational and then it grows from there, right? One person notices something, and that's how innovation happens. And this is the medical innovation that we need to reduce the C-section rate in our country, to improve maternal mortality, to improve infant mortality, to improve the birth experience and reduce birth trauma, and actually learn how to appropriately use inductions when needed so that they're not causing harm in the process of inducing. So we just have so much learning to do, and I'm excited to see where this goes for you.
I just feel like we've been dealing with this problem going on decades now, right?
Yeah.
We've gone on for decades. It's time something gets done, and this is my trying to do something about it.
Yeah, absolutely. Wow, this is amazing. All right, cool. Well, we will link all the links in the show notes, you guys, and I'll see you next week. So be sure to follow me on social media. You can find me at Tranquility by Hee and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by Hihi on all platforms. Until next time, stay educated, stay supported, stay confident. Bye!